You're live.
Welcome, folks. This is House Corrections and Institutions Committee. It is Wednesday, January 21st, and we're going to start our afternoon with discussing the Vermont Medicaid 1115 waiver in terms of being able to provide Medicaid for inmates who are eligible, sentence folks who are eligible for Medicaid, to get them signed up with Medicaid prior to their release, 2 months prior. So I'm not sure, should we start with DOC? Should we start? Do we both want to go up there? What's the best way?
We would like to go be up there.
Okay. Grab a chair, move over, Brian, move over. Move over, Brian, like out in the hall.
Morning, Dave, and they don't tell you, once you get your committee assignment, run to the room.
Yes.
As fast as you can.
True.
Yes.
This is true.
I did not know that.
You were newbie.
I had to switch with Harrison, I think, because he couldn't
Yeah,
hear, he
because
couldn't hear down there.
He was sitting down
I
there.
was.
And then John was up here and he couldn't hear, and then we had to switch.
Well played, Connor.
And then the returning members go back to their old seats.
Mhm.
So it's just kind of, some committees, the chair appoints, tells people where they're gonna sit.
But you're more magnanimous than that, Alice.
Not our grace. I moved in my last committee because Dan moved and he had left food in his drawer. And my entire drawer was full of mouse stuff.
Oh, wait, what was that?
Yeah.
What did you say?
2 years ago. It was full of mouse stuff. The mouse got in there. Anyway. that's-
No, but some committees, the chair tells where the members are gonna sit.
Mhm.
That's how you got Troy and Kevin together, right? The dream team.
That's right. Keep each other in check.
Clerk usually sits here, the vice chair sits there. Those two seats were open. This side was all filled up.
Mhm.
What are you gonna do?
What are you gonna do?
What are you gonna do?
Last person in gets the last chair.
Well, no,
Chatty.
we're to be out on the fire escape, so
It's just,
I'm inside.
anyway,
I'm inside.
Sorry, ladies.
sorry though, you folks on YouTube, we're just getting settled in.
Yeah, we're on.
I'll turn it over to you, both of you folks, and if you could just identify yourself for the record before you start. And I know we have a handout on our website. Welcome. And I would assume you would take questions as we go along. Right. Thank you.
For the record, Aviva Teva, Executive Director of Health, Wellness and Engagement with Vermont DOC.
Thank you, Madam Chairman and committee members, for inviting me. I'm Renee Weeks. I'm the Director of Complex Care and Field Services for the Agency of Human Services.
Welcome.
Thanks for accommodating both of our chairs up here, knowing they're such hot commodities. So I was going to start with an overview. Some of this you heard the beginnings of last week in the context of DOC Health Services, but just some kind of high-level summary of the Medicaid work that DOC has been involved in, and then really turn it over to Renee to address BCCI and their role in it. As mentioned last week, there's really three components of the state's Medicaid work as it relates to DOC and reentry, all of which has been being worked on for years and was implemented as of January 1st, though it is still being stood up. Those three things are, first, that people who become incarcerated while they are actively enrolled in Medicaid have that coverage suspended instead of terminated. Because it's suspended instead of terminated, it's able to be reactivated much more quickly when they're released. The second big change is that we're able to complete.
So how does this work? The suspension versus the termination? How does the suspension, is that true for everyone who's coming through the system who's on Medicaid, detainees as well as those who become sentenced, that it now gets suspended?
Yes and no. So yes, in that it doesn't matter someone's legal status, but someone's eligibility is not suspended until 28 days of incarceration.
So they have to be there almost a month.
Mhm.
And then it's regardless if they're sentenced or detained.
Correct. And that's all automated in the IT systems. And so there's data being sent and received, and all of that is set up to happen on an ongoing basis.
So for those 28 days that they're there, do they lose Medicaid at all? They don't. So it just hasn't, is that pre-1115 waiver? Was that also the case that they could be there for like 28 days before they were discharged from Medicaid?
So I would want to confirm with Diva or other folks, but my understanding is that previously people were terminated when it became clear that they were incarcerated, but that there was no systematic way that that was necessarily occurring. But for example, if someone was coming up on a renewal and they were sent paperwork to their house to send something in so that they would have, you know, a redetermination of eligibility, and they were incarcerated, so they didn't get the paperwork and they didn't submit it, their coverage would lapse. Now it won't, because they will be in the system as incarcerated, and they and or DOC will know that their coverage is going to end, so that we're in a position to help them renew it before it ends.
That's a 28-day window. But previous to the 1115, was there a 28-day window at all? It was immediate?
Well, there was no systematic way, so when it got terminated,
What's the renewal time?
my guess is that was the most consistent way that it occurred, but it could have occurred any way that Diva understood that someone was incarcerated. Because you weren't able to be enrolled. There was no suspension.
You were terminated.
Right. So if known that you were incarcerated, you could not also be enrolled. Now, because there is the ability to be suspended, it's possible to kind of be in that status instead.
And that's true for sentenced and detained. So if a person who is detained and they're there for 4 months and they came in on Medicaid, with the 1115 waiver, they will have been suspended from Medicaid on the 29th day that they've.
Yes. And then 24 to 48 hours after release, the provider portal should show them as active again, as long as their coverage didn't lapse while they were incarcerated for a reason that we were unable to intervene and continue their coverage, if that makes sense.
How could their coverage have lapsed?
So if they were coming up on a 12-month redetermination where they would need to submit additional paperwork to determine that they were still eligible. And if we weren't aware of it or they weren't aware of it and didn't respond with the appropriate paperwork, then they would be.
They're not going to be aware.
Well, they will now going forward receive notifications to their facility address. And
Instead of
DOC will be notified by Diva as well.
All folks who are incarcerated or sentenced, it's not. Is this also for detainees as well, or just sentenced?
Yes, so these first two items are not related to legal status at all. Both the suspension and the enrollment while incarcerated are applied the same way to sentenced and detained people. It's just a question of detained people likely being with us for less time and how it plays out when they're behind the walls for a shorter period.
So there's going to be a shift in Medicaid in terms of the renewal time, where it used to be once a year. Is that going to shift to once every 6 months?
I don't know the timeline for that, but I think that is eventually going to happen. And then I believe the systems that we've set up would still work the same way, and those notices would go to people's facility addresses, and they'll just have to go through the process more often.
So that's going to put more pressure on corrections. Dominated this conversation.
Doing a great job.
No.
No, I'm good.
Okay.
The second big new thing, January 2026, related to Medicaid and DOC, is that we can now enroll people or complete the application for Medicaid while they're incarcerated. We can do that in the online portal. We weren't able to do that before, and we are now. So we've set up a system whereby When someone comes in, we collect all the information that we need from them. First, we say, can we assist you with your Medicaid application? If they say yes, then we collect information from them to be able to submit that. Once it's submitted, we'll follow it from there. Hopefully, a lot of those are kind of immediate approvals and result in immediate enrollment status or eligibility. But if not, we have a plan in place to work people through that, to hopefully enroll as many people as possible. And that's completely new because previously, again, the systems didn't allow it, basically. You couldn't go and submit an application for someone who's incarcerated online if you acknowledged they were incarcerated.
So how many folks that come in are on Medicaid? Do you know? Ballpark figure?
So
Half, 3/4, a third?
I can't answer that question directly, but I can answer a different one that is maybe would shed light on it. So I don't have the numbers for people coming in since January, in part because we're still standing up all the systems, for example,
Sure.
systematically check. However, in mid-December, we looked at all the people in custody on a given day, and half of them roughly were already enrolled in Medicaid with full benefits
And they came in
on that day.
on that.
So yes, that would have been when they came in because our process of enrolling people was really only related to inpatient hospital coverage until now.
Right. So by coming in, do you mean like they're processed into the facility or do you mean like coming into an, you say, mhm.
Yes, sorry.
So I didn't have to finish the rest of it because I was
Well,
saying,
you-
or did you mean coming into a meeting? But okay, I got you.
Admission into the correctional facility. Sorry to cut you off.
Well, in my head, I was like, well, do you mean like they come into an appointment specifically for this or during in processing? But now I understand.
Okay.
Just making sure that I had that correct. Thank you.
And then the third part, which I think we'll really focus on today, is specifically for sentenced people. It's specifically in the 3 months pre-release, which is the Vermont Medicaid Reentry Program, which is enhanced case management that people will be offered if they're enrolled in Medicaid and sentenced and within 3 months of a release date. And that's where the sentenced status matters, because someone won't be eligible for those services if they're detained.
Why is everybody looking at me?
No.
I do have a quick question. So just for clarity, you're able to get them signed up for the Medicaid, but they're not covered while they're in the facility. So when they walk out the door, when they're done with their,
They're covered within that 3 months
right, okay.
pre-entry. What happens previous to the 1115 waiver, whenever anyone entered into the correctional facility, they would lose their medical coverage.
Right.
Could be private insurance, could be Medicaid. Medicare, I'm not sure about, but Medicare. So it was all on the state's nickel,
Mhm.
pretty much, except for hospital care or something like that. What the 1115 waiver allows is instead of the termination of Medicaid when they go through booking and are there, it allows Medicaid to be suspended
Nice.
until they reenter the community.
Okay.
It also allows Medicaid coverage where DOC gets money from Medicaid for that sentenced person beginning 3 months prior to their release. So there's some financial implications for DOC. So Medicaid, 3 months prior to someone who's been sentenced for their release, DOC will receive, correct me if I'm wrong, Medicaid payments for some of the medical and mental health care that's provided in the facility.
Yes, and the benefits that are included in that 90 days of pre-release eligibility are very specific. It's a set of services. So some other Medicaid program or service that someone might have access to in the community, they wouldn't necessarily be eligible for pre-release because it's defined very specifically what services DOC is going to be achieving. So they're only eligible for that subset of services, which are services that we already provide. So this initiative is not affecting what clinical health services people have access to in facilities through WellPath. Those aren't changing. It's just that some of them are now part of a pre-release benefit and thus eligible to be submitted to Medicaid for some funding to come back to the state.
Did we already talk about, we probably did, I just don't feel well today, so I forgot, I'm forgetful. How long, like, so say somebody gets sentenced to 5 years. Is the suspension good for 5 years? Is there like a limit? Or is it just, you know what I mean? Like, is this,
Yes. I can't speak to exactly how it works, but it should be good the whole time. It's not intended to lapse based on how long someone's incarcerated. But exactly how we made that work, I cannot.
Okay.
It's a good question.
Is that on Diva's end?
I would say it's all of the agencies involved because it involves DOC data of incarceration status. It involves DIVA and MMIS, the Gainwell managed system.
so it's complicated.
A little.
Has it been rolling out pretty smoothly or have there been a lot of big hiccups?
There's a lot to figure out how to make work on the ground. But nothing feels like we can't figure it out, if that makes sense. But there's still a lot to work through, troubleshoot, bring the right people into the room and, you know, make sure that the systems are operating the way that we thought they would, that the right people have access to the right information. When things work differently, they know why it's happening that way. And we're still very much in that process of working through all that.
And how did you roll this out in 6 facilities? Are you finding some facilities are more tuned into it than others, or is it about equal? There's some glitches in some of the facilities.
So in terms of the suspension and the enrollment, we're working across the system kind of at one time, pulling in people who have a role to play at whatever facility. And I would not say there's been clear differences yet. We're still standing up the programmatic element that Renee can speak to more in terms of what BCCI really does. And I think we'll see over time with that. But I think it will take months to really have a good answer to that question. And it might be about resources in the community near a particular site. It could be, you know, for any number of reasons. All right, did you move me on? Great. So the Vermont Medicaid Reentry Program, which is this additional enhanced case management that eligible people will be able to opt into, will be offered, is meant to be short-term, intensive, whole person coordination. Again, to be eligible for that extra set of services through BCCI, people have to be enrolled in Medicaid, though it might be suspended, but they'll still be functionally enrolled, and be sentenced, and they also have to be within 90 days of a projected release date. It's a voluntary program. People do not have to participate. That will be explained when people are made aware of the program as an option. And it's really meant to serve as a bridge to the community to help people get connected and established to services kind of beyond the services that are already in place and the staff that already are playing those roles. And finally, the expectation is really that it improves continuity of care from the facility to the community because of having additional resources and staff and kind of coordinated collaboration across all the entities involved. So some of those dedicated staff are in each of the main entities involved. So I think we could go to the next. Thank you. For the medical contractor, that looks like nurse discharge planners. At DOC, it's primarily reentry caseworkers who will be involved. For probation and parole, there are reentry POs, and then 6 staff at BCCI. And so all of those people and others, but those are the primary, will be working together to provide reentry services and release planning to people in the 3 months prior to release.
So those 6 WellPath nurse discharge planner, 1 per facility? Is that
Yes.
how it breaks down?
Yes.
And then the same for the reentry caseworkers.
Yes.
And is that true for the CCI,
Yes.
one per facility,
CCI.
chronic care?
Care
initiative?
initiative, gotcha. Thank you.
I'll turn it over to Renee.
So I'm just going to give a brief overview of our Vermont Chronic Care Initiative program in general, and why we thought that it was a good fit for this work, this reentry work. The Vermont Chronic Care Initiative has been around in Vermont for 20 years now. And we sit within the Agency of Human Services Central Office within the Healthcare Reform Team. We're comprised of 16 nurses in the community right now who provide care coordination services to vulnerable Vermonters. Our philosophy is really to provide a holistic, team-based care approach to people with chronic health and social needs that are complex. So that's the population that we serve. Right now, all of the people that we serve need to have Medicaid. And they're typically disengaged or not receiving services elsewhere. So they may be experiencing homelessness and have diabetes and aren't connected to healthcare services. So our team comes in and we help them get connected to their healthcare provider, a medical home, to a housing provider. If they're just as involved in the community, because VCCI and Department of Corrections have worked together for years now, we involve their probation officer in that care team as well. Many of the people that we work with have really poor health outcomes without intervention. So our goal is to provide short-term intensive case management services to get people connected to the providers and benefit programs that they need to be successful in the community. And the way that we do that is on the next slide. Some of our core functions are, and this will apply for the Vermont Medicaid reentry program work as well. We will screen and assess people to see what their health and social health needs are. So assessing the social determinants of health, such as housing, transportation, safety, social isolation in the community, so we can get an assessment of what needs they have in the community. One of our primary core functions is to connect people to medical homes, even if they don't have an acute health condition now, so that they can get tied in for preventative care. We help members and the people we serve navigate our complex systems in healthcare and mental health and substance use. It's really hard for people, especially those reentering the community, to navigate all of that, especially if they've been in for a while or aren't returning to providers that they were connected to previously. And then we also just do an ongoing assessment of needs because we know those change over time, and we update an ongoing plan of care. The model that we use is a team-based care model, and we've been promoting that throughout the state for several years now. We had a learning collaborative with all disciplines of care in the communities over the past year and a half. We meet with members in their homes and in the community. We really leave it up to them where their preference to be served is and where they're most comfortable. And then the care coordination tools we use as part of our process are kind of getting an eco map of what relationships people have to see who needs to be part of a care team. And we facilitate a care conference and develop a shared care plan with all the providers involved in that person's care. so that there's transparency around roles and responsibilities and meeting the goals in the care plan. And the providers know what other providers are doing with regard to that person's care and goals. So we're using that same model in this program as well.
So for all of this that you provide, core functions in the care model, is 6 people in your world gonna be able to take on everything that someone who's reentering faces?
Not alone, but with the team of providers, I think that it will work. They're convening the team of providers in the community and making sure those connections will happen and that people get established and engaged in those services before we would then discontinue our services. We have up to 6 months in the community to work with people to help make those connections.
To get it all started?
Yes.
John and then Troy.
Yeah, it kind of rolls from that number. So you have 6 of you, so it's kind of covering about 150-ish people, right? If everyone can handle 25, does that meet the need?
That's a question that we don't know yet.
Well, I
Yeah,
see.
we had to base that number on some projections that we worked with DOC on people that would be eligible coming out. What else did we look at?
Of eligible people, how long people would be in the facility pre-release while being eligible, because that'll affect how long they're on a caseload. And then on the other side, there are also assumptions around how quickly someone comes off a caseload. So some people will be able to be connected and sort of a warm handoff will occur to another program that's providing, you know, longer term support. And then some people may be with BCCI up until that 6 months. So there's a lot of projections involved in those numbers that we'll see as it plays out, which ones we were, you know, made accurate projections.
So this just got going.
For the 1115 waiver.
Okay,
Yeah.
so this is so are you seeing people at this point?
We just received our first referrals.
Okay,
from
great.
The Department of
This is just-
Corrections that have their Medicaid and they're ready to go. And I think we've been in the facility this week, meeting with people to do that first step, which is the assessment phase, to see what services we're going to need to connect them with in the community. And then we're scheduled to meet with more people next week. So it's just barely starting.
Coming out of your cocoon.
Yeah.
Troy?
Couple questions. So these 6 are exclusive to the reentry program. Is that accurate?
Yes.
Can you talk a little bit about what standing that up was like, recruitment? How easy was it to fill? You're full. You're 100% full staffing.
We will be as of Monday,
Yeah.
yes, or minus, we're still recruiting for a care coordinator in the Rutland region.
Okay.
But otherwise we will be full minus the Rutland position.
So how easy or hard was that? Get this going?
It was surprisingly, we had many candidates for each position. So it was a competitive process. And I was thrilled that the people applying really were committed to working in this program with this population of individuals. You know, some were internal candidates from the state, some were external, but all very passionate about this program in particular.
They're all state employees.
They will be, some were not state employees to begin with, some were.
No.
2 questions. So the first one you said was that you filled all 6 positions except for the one in the southwestern region. Is
Yes.
that my understanding? Okay. And then for the 25 people per coordinator, is that about standard with general healthcare practice?
With Vermont Chronic Care Initiative, yes, for this type of work.
Did any of the care coordinators, the 6, that you've got 5, any of them come from WellPath? Did any of them work at WellPath?
No.
Any of them work within DOC? At all?
No,
I'm just curious.
Picking up what I was putting,
Huh?
said you're picking up what I was putting down.
It's dangerous. So you and I. on the same page. Wonderful minds think alike. Oh, that's dangerous, Mary.
So the places that you have listed here, is that the agencies or where are they meeting with people in those communities?
So they would be meeting with people in the correctional facilities, in the community with which they're placed.
Okay, so like Southwest Vermont, where I'm from, it would be in the parole, would it be parole?
When at post-release, they'll be meeting at the state district offices, or meeting with people at Marble Valley in Rutland. Yes.
Post-release?
They meet pre-release and also do a warm and post-release until they can get established in the community.
Our goal is because people, really, everything is relationship based in this work. And our goal, we don't know how it will wash out, but is to have, if I'm in the Newport facility and I'm being released to Rutland, I'm going to start my services with the care coordinator in Rutland. And we're hoping, well, DOC, the goal is to get them in that pre-release window at some point down to the Rutland facility so that case manager in Rutland can begin the assessment phase and begin working with them in that pre-release time. And then they would be doing the post-release care coordination as well. So a justice involved individual would get the same case manager in the pre-release window and the post-release window. We might not be able to make that every single time, but that's the goal.
Good.
So that's something we'll be tracking.
So one thing that's coming through my mind is, and I'm looking at language, we updated the statute a couple of years ago in terms of the medical handoff for prescriptions. Because that was the biggie, be it your normal prescriptions that most people have for whatever, blood pressure, heart disease, cholesterol. How do you see this, the seamless transition from the incarcerated setting to hooking them up with a pharmacy in their local community that they're going to re-enter to? How do you see the 1115 waiver working in that particular arena, and also with the MAT or MOUD, where they're only given enough of the medication to carry them until they can hook in with a hub or a spoke? So how do you see the 1115 waiver working on that when they transition to the community? Because a lot of these folks may not even have come into the facility with a primary care provider or a listed pharmacist that they've been working with, or they've been incarcerated so long that the provider is long gone, so they don't have a provider and they don't even have a record of any pharmacy. So how does the 1115 waiver work for this?
So I think the way we envisioned it was that once that assessment happens with the care coordinator, we'll know what needs they have. They need a primary care appointment. We can make that appointment then, so that rather than waiting until they're released to make that appointment. So it gives us that 3-month buffer. So maybe the wait time to get a provider isn't as long as it would be if the planning was just starting after they were released.
But what plays into that 3 months? I'm just going to be a devil's advocate. That they need approved housing. So the person may think that they're going to go to one place, one community. DOC knows differently because they've heard different information from supposedly where the inmate thinks they're going to go. DOC may have heard different information from that person. And they may not verify someone's housing until maybe 2 or 3 weeks prior to their release. So how does that work in terms of figuring out those connections with the providers on the outside? It leaves you a short window.
Barrier, yeah. I mean, we'd have to switch plans at that point if they were going to a different community than originally planned. And that could delay things realistically.
But hopefully the team-based care model in this context where the DOC caseworker is very involved and to the prescription question, the WellPath staff is involved. It will facilitate information sharing. So as soon as that plan changes, the BCCI person would be able to have access to that information and figure out what adjustments need to be made. So to use again the prescription example, you know, we want to provide a certain as high as possible level of release planning, whether or not someone's in this program. So a lot of that care coordination, appointment setting, continuity of care is still WellPath's responsibility, whether or not someone's in this program. But if they are, then that information will be shared with BCCI so that they can have more eyes on it, fill in gaps, and then also be there if something changes, like someone being released somewhere other than what they expected, to do that kind of last minute, what do we need to shift to support them as much as possible when they do come out?
One other question, I hate to dominate this. What if the person's having trouble getting an ID?
That's something that, you know, we can help them with.
Can you identify yourself for the record?
Sure,
please?
would. So Brendan, I would policy director for the Agency of Human Services, and when I was at the Department of Health as the policy director, we implemented a process that allows folks easier access to getting identification to come out of resolution. So the options available here with an affidavit. So it should be it's that kind of a policy level. Easy to navigate.
Would it be?
We've seen the numbers in this in thousands since that was some years back. So.
I'll shut up. And then your document, did you have more, Haley?
We have some essentially like visuals about what the process is going to look like that we can run through if the committee would like.
I think it would be helpful.
Yes.
So this is going sort of zooming back out from the BCCI component of this is a bigger picture of what happens related to the Medicaid pieces, those three, the suspension, enrollment, and referral. So, sure, perfect. So when someone becomes incarcerated, WellPath will confirm if they're already enrolled in full Medicaid benefits. If they're enrolled, then that suspension will happen automatically after 28 days. If they're not enrolled, then DOC will collect the information from them if they opt into assistance with their application, and put that information in our system. At that point, WellPath will submit the application. And from there, the application will be processed just like anybody's submitted Medicaid application. Then, if someone meets the eligibility for the Vermont Medicaid Reentry Program, the services component through BCCI, which means that they're enrolled, but they're also within 90 days of a projected release date, which may or may not mean that, you know, housing has been established. You raise the question of if someone's housing isn't confirmed, it will delay their projected release date and would delay their eligibility for the program. But if they have a projected release date and they're 90 days from it, then the caseworker will share information about the program, which they will have already done likely, but they'll revisit it and say, you know, either you said you were interested before or you didn't, but you have this opportunity again, you're eligible. They'll share a flyer about BMRP and BCCI. And if someone opts in, we can go on to, I think, 2 from here. I might have gone quickly.
Just a quick question. Do you have any thoughts or data on the likelihood that someone's going to opt in when they were not already in?
To the Medicaid application assistance?
Yeah.
No, and we, in the past few weeks, have seen more people turn down that assistance than we expected. So we're strategizing about providing more information upfront about the benefits of
Do you know why
enrolling.
they're turning it down?
Not yet.
Okay.
My hope would be that we solve that and that most people
Yeah.
opt in because it shouldn't take that long to provide the information and we want them to be enrolled, but we'll have to figure it
They're
out.
not even willing to opt in to getting those services 3 months prior?
Well, so what I was
This is
just referring to
fine.
is the application assistance, not necessarily the programmatic services through BCCI.
This is upon entry.
So they have to opt into both. When they come in the door, they have to say, yes, DOC, you can submit an application on my behalf
For Medicaid.
for Medicaid, if they're not already enrolled. And then when they're within 90 days from a projected release date, if they were already enrolled, because they could have come in enrolled, then they'll be offered, do you want to opt into this program with BCCI? Or if they did not come in enrolled and did not accept the assistance, they wouldn't be offered the service because they won't be eligible.
Is it because they don't trust DOC?
It could
I
be.
don't know.
I think our processes are so new. I could be wrong, but my read is that we'll be able to figure it out so that most people opt in and it's just tweaking something. I'll be very concerned if that's still true. You know, a little bit down the road from right now, but right now we're standing it all up. And so
Yeah.
the issues could be in a million tiny places.
So the word of mouth between offenders needs to get out there too. It could be a lack of trust or just a real lack of understanding that there is healthcare out there for them.
Yeah, I mean, I was gonna, because people sometimes have a tendency, you know, if they're coming in and they're just being, you know, admitted, it's a lot. And they may be like, no, I don't want that because I don't want anything right now, you know, but is there another follow-up or is that their last chance or?
No, it won't be.
Okay, good. That's what I was gonna say. Like even like a week later, hey, I know it was a little rough there that night, but we also wanna, just as long as there's like, we want them to get this. You know, you want everyone, you know, it's too bad it's not automatic enrollment, but anyway. All right,
We were talking today, actually, in our huddle meeting that we have about people, they might not opt in that pre-release, but once they're in the post-release, they might say, hey, yeah, I do want that service. And being able to opt in at that.
as long as you're well aware of it.
Yeah.
Obviously you are, so thanks. Yeah.
We're trying to make as many points as possible to bring people in, even if they previously, either we missed them or they opted out. So if someone they are enrolled, they're eligible, they're within 90 days, they get the information about the program and they say, yes, I would like to participate. They sign a release of information and then that referral is sent to BCCI. And so that there's a couple parts of that. DOC sends some of their information, enough information to make up that referral for BCCI. And in addition, WellPath will send health information, a summary of their health information so that the BCCI team receiving that referral will have a pretty good preliminary snapshot of somebody's, the level of intensity of their medical needs at that time, and other details like at that time where it looks like they'll be released to.
I know enough that it's dangerous. And then I don't know enough. So when someone's incarcerated, they have all sorts of release of information forms to sign. And I would assume one of them is for their health care in terms of what information can be released. What if they refuse to sign a release of information of their health care? Does that impact them with this program at all?
So we decided that the program wouldn't work if someone wasn't comfortable with their information being shared. And the release of information covers both DOC and medical information maintained by WellPath. So that opting into that information being shared is a prerequisite for participating in the program.
And how many folks do not sign that release of information in general? And that may be a question more for DOC, because I've run into this at times with constituent issues where it's pretty clear the offender did not sign a release of information.
Yeah, so for this program, we just need time to see how often people are not opting in and get a sense of if that is related to the release of information. But for releases of information in general, separate from this program entirely, we're working on streamlining that process. Some of what happens sometimes is there's a disconnect between releases of information and for WellPath and for DOC, and they're saved in separate systems. And so constituent services, this again, just they can't access the WellPath release of information. So for that, what we're working on actually currently is a process that for certain types of releases, it will cover both. And so there won't be so many opportunities for something to get lost, basically, in between the multiple systems where information is stored. So hopefully you hear fewer issues going forward, but that's a bit separate from the ROI for this program.
And would there be any hesitancy on the offender's part of family members knowing about this 3-month reentry help? You think?
I'm not sure.
That's sometimes my release of information is not, they don't sign off on it because they don't want family members to have access.
So to participate in the program, the release that they'll sign won't include family members. Later down the road, if someone says, I want my family member to be part of my care team, it could. But they're at the onset, it wouldn't necessarily be there unless they specifically note that they would like them to be included.
And who's going to get all of this information out to the person in the facility? Is it one of those, the chart, one of those?
There's people who are eligible for the BCCI support.
Yeah, I mean, just for all the little nuances, not even to sign up for it. Is it going to be the WellPath nurses? Is it going to be the reentry caseworkers? I mean,
So
folks are going to have to be walked through this, the sentence folks.
yeah, so the formal referral is made by the caseworker. They're the one that puts in the system, they collect the opting in and the release of information. But those other staff that you mentioned, we're also expecting to be kind of ambassadors to the program and to tell people about it and to be able to speak to what the benefits would be and to encourage people, hey, I see that you might be eligible, talk to your caseworker about this. We also are planning to further identify ambassadors within the facility. So for example, the open ears coaches, so that there's that kind of as wide an awareness of the possible benefits as possible so that people can, through word of mouth, learn about it if they had missed the other information channels.
I think your word of mouth is how people are going to find out about it. Your word of mouth.
And BCCI will be in the facility. I think that'll help.
Yeah.
New staff and in-person meetings should.
If you don't mind, how'd you get involved with all this?
Well, I've been working in Vermont for 27 years. I did the math before I came here. I was like, am I that old? But my background is psychology. I'm a licensed mental health counselor and a licensed alcohol and drug counselor. I worked at Clara Martin Center for years as a clinician and became a program manager. I worked with Department of Corrections for many years, facilitating violent offender and sex offender programs, and then worked at the Upper Valley Haven for 11 years in the housing world, managing their shelter and case management programs before coming to the state just 4 years ago.
Nice.
To do this, to try to have a broader systems level impact in improving our health and social service systems.
Lucky.
So this was a great fit into our work at the Vermont Chronic Care Initiative.
Great.
We've been partnering with DOC for 3 years, so.
Yeah, thank you.
I have a lot of hopes for this program. I hope it really works because it will make a difference. And I think it will really help some of the statutes that we've updated in terms of helping folks re-enter the community and make those connections, because health insurance has just been such an issue for folks, and that has prevented folks from accessing care that they've needed. It's hard enough to navigate the whole system when you know what's going. You just have the tools to work with, and to think that folks just don't have the tools, and then we expect them to be successful. Anything else? Sorry, I dominated the conversation. Though I read Troy's mind. Anything else?
Outstanding.
Thank you.
Yeah, thank you.
Oh.
Perfect timing. Renee, thank you.
Thank you.
Thanks so much.
Nice to meet you all.
You all right?
Everything's good.
And you connect, because you sent me that email.
Yeah, toss it as you will.
Let that be a warning to you, what will happen.
There you go.
I don't know.
I don't know, it's been nice.
I have one guess.
Too small for me.
But I'll tell you, Brian,
What's that, dear?
if not for the peanut butter sandwich
Yeah.
today, I would not have gotten my out.
Good.
Everything's great.
You're not on your way. Out?
I do this again.
So I can solo home.
I'm back.
Doctors in one morning.
Didn't see that one coming.
Yeah, yeah.
Call that.
Figure
Watch out.
where-
Approach is in the house.
More tomorrow. Yeah, they're here telling us we have more money to work with.
Yeah, yeah, we'll take care of it, Joe. We'll spend minutes.
Thank
Have a
you.
nice day.
Budget, 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 budget.
I'm sorry.
Yeah. Do you have copies of language there? Oh, no, sorry. Tape, so people know what we're dealing with.
This is the screenshot.
Did you post that? You
Yes.
posted it?
For the document.
Yeah, well, here we go, the ups and downs. Ha, ha, ha. Yeah, that goes down to Mary, and this goes down to Kevin. Start with your ups and downs.
Mary.
It is for Mary.
And Kev gets one of those too.
Yeah,
Thank you.
but this just says what's the differences. Doesn't. Okay, Okay, that's for Mary, that's for you,
Well, I got one of
that's
those.
Kevin.
I'll give that to Will.
There you go.
Oh, then we got more here, hang on.
I have one of those too.
Okay. We got a lot of documents here, and we have Representative Squirrel from Appropriations here that's gonna give us some help and backup. What's your time frame, Trevor? Short?
It's well played.
I'm thinking maybe, should we start with, I can start with DOC, does that work? Or is it better for you to start with you?
You want to hear from them. So if there's any questions around the money or dollars and the BAA, I can speak to them. very quickly.
Okay. So for the committee, this is the first thing you need to look at. And it's also on our webpage. Okay. So what you'll see, and this is in the governor's BAA for the general fund. And the chair of appropriations showed this to me, and Sean happened to be walking by, and Sean and Kevin are our liaison to appropriations, so I hauled Sean in. So where you see the asterisks, 3.1 million is for FY 25 Wellspring, WellPath staffing invoices that are being paid for out of the fiscal year 26. You got a problem? We're okay? So it's fiscal year 25 that finished up June 30th last year. So it's invoices from July of 24 to June of 25 that we're being asked to pay for 6 months into the current fiscal year 26. So the question is, why? So there's three.
Maybe I should come up.
That's, so we need you there.
So that's 3.16, 3.1 million plus. You can sit in the red chair. not the-
That's it,
that one.
that's it.
And then the other piece is 4.5 million plus for Wealth Path staffing contract amendment due to the increase in average daily population. And the big question that the chair of appropriations had is what's in their contract that allows this and why is this happening? So between the two, we have more than 4.6 million, 8.6 million.
Yeah.
Between the two, 7.6, almost 8 million between the two. So that's a big number for BAA. So that's why your chair reached out. So, Trevor, welcome.
Welcome,
And you-
Representative Trevor Squirrel, to House Appropriations. Let's take the 33.1 million, which is the real invoice from 25. As most departments and agencies have problems with the vendor payment system, some of these things are split, okay? And that's, at least that's what I was told, okay? And so it ends up getting paid that by 26. I asked the question because we get a report on carry forward and reversions from all the line items in state government. And when I looked at the correctional services line for carry forward and reversions, only showed about 900,000. So if everything was equal, then I should see at least $3.1 million being carried forward in 26, which I didn't see. So I've had a conversation with the deputy commissioner. And as current as half an hour ago, I've asked Haley to get back in touch with her because she was supposed to get some information to me, which I haven't seen yet. Okay. It was explained to me that what happened is for budgetary reasons, they had that money available at the end of the year because they weren't paying that invoice because it was being carried over. And they used it, in part at least, to pay more to the PAC. In other words, the PAC, they had so much for PAC. And because of overtime and other workforce issues, they had to pay more. I don't know what those numbers are right now. And I believe there might be some other invoicing that's in that number. So that's all I can tell you right now. That's the explanation of what's happened. I just don't have the specific numbers. When I do, I can present them to the committee.
So some of this is kind of the, I don't want to say backfill. I mean, part of it was with the vendor system because that got changed. So invoicing got delayed.
Yeah, they're not the only ones.
Right, that was across the system. But also they used some of the money that they had that didn't go because the invoices weren't coming in. So they used some of that money to pay for staffing.
I won't say, I won't, part of it was pay act. I think this is a conversation that DOC had with that central office and their finance person. That's my understanding. And, is that correct?
Yes, the carry forward for 3.1. That was for, we paid 13 invoices. We had 13 invoices to pay for 2025 instead of just 12. So that 3.1 was carried forward that AHS was turning over to us to pay for that extra invoice. And so that's what that was for. And my understanding is that's net place, that's net neutral, but it's not new money. It's actually carry forward that we're using to pay that 3.1. But that's just 1 month. It's not several months.
So we're in a different world money-wise than appropriations. So can someone explain what carry forward means? And maybe you could identify yourself for the record.
I'm sorry.
Oh, that's fine.
Marlene Batia, the Executive Director of Finance for the Department of Corrections.
Carry forward is a reconciliation and show a true up at the end of the year for every department and agency. When they have a budget, let's say they have a budget of $1 million and only spend 900, you have $100,000 left on the bottom line. Finance and management comes in and knows that their $100,000 is on the bottom line. And they'll either let you carry it over because maybe you didn't expended on programming and it's to be completed, right? So you would hold it within your budget going into the following year. Or finance and management will say, well, we're gonna revert all back into the general. Fund. And there's one other element of that, when there is carry forward, there can be a decision made between the department agency and finance and management to use that carry forward for pay.
So that's what happened in this particular case.
So it is not new money. It was existing FY 25 money.
Well, yes and no, because that money carries over to FY 20. We're backfilling it because if it just carried forward, we wouldn't be putting it in the PAO.
So you're backfilling.
Yeah. Yeah.
Because the money was used for the pair.
Or the invoices, as you suggest.
Right. This was for an additional invoice, 13 invoices instead of 12 for 1 year. And the next year, this year, we're going to be paying 12 in 1 year. So that was for that one extra invoice.
And the invoice was for what in particular? Was it staffing or was it?
It was for WellPath. It was for WellPath. It was 1 month's payment.
For staffing.
Yes.
You're talking about the 3.1 million.
Right.
I'm talking about the money that was left in the FY 25 carry forward the invoice to pay all the invoices. And that's the information I'm getting from the president.
If anybody can follow this, good luck. Yes. Other committee members, can you follow this?
No, I kind of can. Yeah, I mean, just, I guess my question is, so that 13th payment, right? Was that like a surprise?
No, it was, I think it was probably towards the beginning of the contract and they were making the payments the same. Well, now we receive them, we pay them in the next month within a couple of days of the next month.
Gotcha.
So that was really what happened. It was 13 in 1. And then and that was the AHS had held that so that we could utilize, as he said, 25, 26. And those are things that are decided upon at the end of 25.
Okay. Gotcha.
Well, I think appropriations committee needs to work with you a little bit more to really understand what's going on. Because I think
I understand what's going on. I just need to get the information. When I do, I'll come back to this committee.
Yeah.
Can I try to summarize and hear where I'm wrong? There was some amount of money left from FY 25. And that's a portion of the 3.1 million that we're talking about that was used to pay this 13th invoice from.
Yeah,
FY
the carry
24.
forward doesn't become part of your BAA request.
Okay.
and this is the 3.1 as part of the BAA request.
Yeah.
So your carry forward doesn't become part of that.
Well, there wasn't that much carry forward. It was only 900,000.
That was part of it, yeah.
That's
But so my question is, so if you knew that there's 13 payments, then you budget for 13 payments and it would already been in there, you wouldn't have to be moving money around to pay for the 13th payment. So how did like that happen?
The budgeting was done for 12 payments with that.
It was a full pot, a little boo-boo, a little oversight.
And where does the budgeting for that, is that within DOC or Agency of Human Services or?
Budgeting for WellPath is in DOC. But at AHS, it goes through AHS, and anything that we do for budgets has to go through AHS.
There was 12 and not 13 if something doesn't seem, something was amiss.
The best guess, Representative, minus that carry forward, that 900,000, we should anticipate a 2.2 adjustment on this line.
what I'm saying is that when I saw the request for 3.1 million,
it didn't line up.
I would assume since you're paying it for 26, you had money on the bottom line. And
Right. We thought it was.
That's where I would look for that.
We only found
Looking at the
900.
report, it shows 900,000 instead of what 1.2 or 3.1 or whatever.
Yeah.
So that's when I started asking questions, why that happened that way. And I was given the information that part of it was an increase around pay act and some other inputs, which is you referenced other inputs. I just don't have that information.
Okay.
So maybe all of us can sit down at some point and sort this out.
That would be helpful, and then get back to us.
Yeah, I'll get that. And actually, the 4.5, that's a combination of an increase in the well path contract because of the census change. And I think also the substance use disorder expansion. So I think that's understandable. This committee knows about what's happening to the census and in corrections, and obviously has a direct impact on the health services. It's a big number, but it is what it is.
And there's no carry forward, right?
For that.
Well, I mean, that one seems pretty straightforward, but the first one, 3.1. That one definitely needs.
Yeah, I think it's more about understanding what exactly happened.
Yeah, exactly. It probably all make perfect sense.
So Trevor, when you have those conversations with the 3.1 million, the staffing, the invoices just circle back to us. Okay. And then the 4.5,
I'll let them speak.
yeah, we'll take you off the hot seat.
I never feel like I'm on the hot seat.
That's good. But some people do.
Hot seat's here, you chose well, yeah.
May I be excused?
Yes.
Thank you, Trevor.
Thank you,
much.
Trevor. It was a
Thank
big
you.
help. It
Yeah,
was a
good
big
afternoon.
help. Thank you. Okay, now we got two chairs. We got a red one and a black one, and you can.
Reading, I know Joe, yeah. Gone.
Is he gone?
Yeah, he is.
Oh, well, never
Take
mind.
in and take out.
Sitting the two red ones.
Relators.
It's deja vu.
Okay,
Oh, yeah, well, there's this explanation.
I'm curious on this one. This is one I'm curious on too. Okay. So again, if you both could just identify yourself for the record, please.
Arlene Batty, Executive Director of Finance for Department of Corrections.
Welcome. I don't think you've been before this committee before, have you?
No, I started in June.
Oh, you poor thing. Oh, boy.
Condolences.
Condolences, yeah.
Aviva Teva, Executive Director of Health, Wellness and Engagement for DOC. All right, shall we jump into this topic? Nice to see you all again. All right, so for this 4.55 million, it's coming from two places, two drivers of changes to the WellPath contract. The biggest portion of it is due to a change in average daily population. So we'll come back to that in more detail. And then a portion of it is for the Burlington Response Recovery Project for enhanced SUV services at DOC.
Now, is that in response at all to the accountability court?
Yes. So I believe they're the same thing. It's different names for the same initiative.
But it was $1 million increase because of the accountability court?
Yes, for WellPath staffing to provide the extra services. Services we weren't previously providing.
And what service? Okay. Again, I know too much.
So you know too much.
I know too much. And this, so this 1 million, let's go back. The 1,080,000 is for increase in services from WellPath to the folks who came through the accountability court. Is that in the Chittenden facility as well as St. Albans?
Yes.
How did WellPath know that the folks coming in went through the accountability court?
Speak to that. For the record, Haley Summer, Director of Communications for DOC. So I think Dr. Luger talked about this a few weeks ago, which was that there's no direct pathway right now for that notification. And staffing for that program hadn't quite, the person hadn't started yet, but now has started. And so the intent is to be able to provide those services to more individuals, aside from just those that are coming in from the accountability board.
It's only 10 or 12 people that came in from the
It's a
accountability.
relatively small
Yeah.
number, yeah.
So WellPath does not know. The testimony the WellPath is given to Joint Justice Oversight as well as to here. When someone is accessing health services at WellPath, they do not know if the person came through the accountability court or anything. They don't know anything about the person, the charges, the conviction. They just know that they need to deliver healthcare to this individual. So this is just the beefing up of the substance use programming within WellPath at the Chittenden facility in St. Albans. And it's for the whole population, not just the folks coming through the accountability court.
So the expectation is that we can bring more people into the program to take advantage of the enhanced services or find more people who would benefit, but it was set up specifically for people coming through the Chittenden Accountability Court. And you're absolutely correct. Regular health services are provided exactly the same. However, WellPath could receive invitation is the wrong word, a request to assess someone for the enhanced services. It's an enhanced, more robust assessment, and then provide the services from there. And part of the rationale for staffing WellPath to do this is they are already providing care to that person if they're in our custody. So to have more of an integrated program where we're building on the services they're already getting, they may have a MAT case manager, they're on MAT, they're seeing, a doctor for whatever, that those services for that person can be all provided in an integrated manner, if that makes sense, compared to bringing in a new program to provide some services that wouldn't be integrated with the services someone may already be receiving just by nature of being in our custody.
So what other new services would they be receiving that will be integrated? And this would be for the whole population that's going through WellPath, correct? Not just those 10 or 12 people from the accountability board.
So currently, the services are being offered to people coming through the court. The service
A small number.
$1 million, but
Is it, that's the question. Is it $1 million worth for those small number of people? It's a handful of people that we heard. It's like 12 people.
Yeah, the $1 million corresponds to a staffing number that is for a larger group of people
Then
than the current volume of people coming through the court. Yes.
Is it a timing thing or is it due to these 12 people? I could hear that you're just now catching up with staffing you need and it's in the same time frame as the 12, but maybe not. That's the question is, why did it happen?
The ADP driven cost increase is a bit of a catch up. I can speak to that, but the 1 million associated with the staffing for the enhanced SUD services was specifically added for that initiative.
So,
Now, we've also recognized that there are more staff that we have that will bring online with that money than the current volume of people coming through the court. And so we want to identify people who have the need for the enhanced services, which is an enhanced level of SUD treatment than we otherwise offer, to provide it to them. But for now, we're really focused on the people coming through the court.
so that's the question. What are those enhanced services? Is it language? Is it new equipment? Is it what are the enhanced
It's,
services?
so I believe Dr. Uliger used an analogy a week or two ago around dosage, and kind of the level of intensity of a service. And so in oversimplified terms, the amount of therapy and counseling and groups will be much greater than if we didn't have this enhanced service, then someone might be able to access if they were incarcerated in our facility.
So they're on
get more.
MOUD program. Correct.
Exactly. So they would be on MAT already. And without this program, they could still participate in groups. Depending on the facility they're in, those groups would be different. They will still receive counseling. They may see a mental health clinician. All of that is still true, but there will be more groups and more therapy available to them to more mirror an intensive outpatient level of care, which currently the amount of services available in those categories don't meet that level of treatment.
Good. No, I'm not good.
Well,
Any of us.
The reason I'm not good is because I don't know who decided that higher level of support is necessary. It wasn't authorized as far as I know.
Fifth floor. Fifth floor with the accountability court.
is this million plus anticipate that the volume of care is gonna be needed going forward? Or is this, because there's not a determined future for the accountability courts right now. In fact, everything
It
I've
ends.
heard is that it's winding
Well,
down.
the governor did say it was the pretrial supervision is going to be expanded.
But is that gonna result in more of this higher level care? So is that $1 million anticipatory? Is that, I guess that's my question.
So the staffing proposal was based on joint kind of collaborative program design for what enhanced services would look like in association with the Chittenden Accountability Court, DOC, WellPath, AHS. I don't actually know exactly who was involved, so I don't want to misrepresent by not naming other entities, but it was the discussions of what enhanced services would look like, what we would provide to meet the criteria of an IOP inside the walls. And then the staffing was laid out for 2 facilities. So the idea was we would pilot this enhanced level of care at 2 sites, and that's what the staffing is based
Okay.
off of.
So can we anticipate if you go to contract for another 2 years, that it's gonna need that, at least that much more going forward?
I think there are people in our custody, whether or not they're part of the program, who would want and or benefit from
agree.
more
I
services.
don't
But
disagree.
otherwise, I can't really weigh in on whether or not it would be prioritized as an initiative. I just don't know.
Right.
I feel like I'm in danger of going over the same ground. I just want to make sure that I understand. So the 3.5 is because of the increased population. The 1 is because of the increased offerings, services. These 2 numbers are meant to cover all of the current fiscal year 26 to June 30th.
Yes.
These increased services, even though they came along with the accountability court. Nonetheless, they're being offered to everyone possible in the 2 facilities.
So
Who needs it?
currently, we're focused on people coming through the court. But if we get a green light to broaden, then we will identify people who would benefit from that level of care and identify more people to start a more robust assessment for, and then determine if they need more therapy groups.
But so then
counseling.
for at least right now, then this million is for the year through June 30th and is for only the people coming through the court, those, whatever the number is.
How does WellPath know that it's only those people coming through the court?
Because they're doing a more robust assessment for someone coming through the court. If
Coming through the accountability court?
Yes, sorry.
That kind of contradicts the testimony that WellPath has given.
Yeah.
That's what I'm trying to connect here.
Related specifically to the accountability court folks, there is someone at DOC who, continuously checks the docket to see who is moved into DOC testimony. And so I believe that's kind of the mechanism for providing that referral to WellPath, that this person should have an enhanced assessment.
I think you're setting yourself up for a lawsuit, because there are other people who are part of MOUD that might not have access to these increased enhanced services, and they're serving the same sentence.
Yep.
And the testimony we received from WellPath and Joint Justice Oversight, as well as right here, they don't differentiate between the accountability court or any other path into the correctional facility to provide these other services. And they're rolling this out across the system for folks who are in MOUD to also provide these other supportive services. And I've asked Haley this morning, now that the budget's been proposed that DOC has a structure for this, and I want to get that information so we can track with our legal counsel, our legislative counsel, to make sure we don't have to update the statute. Because I think we will in some places. And this is connected to the MOUD program. And we have 50% of our population on MOUD.
Mhm.
So I'm just trying to connect the dots here because I'm feeling like we're getting conflicting information.
And if I might add, if this wasn't labeled as being part of the accountability report, I could probably live with the number and still have questions. I have to say, I think everybody in the room has the same questions about the legality and statutes, but 1.08 million for basically it's 12 people. I don't know if it's 12, could be 13, could be 11. I don't know. People keep saying 11, 12, so I'll say 12. That's a lot of money. And so I don't know, just like, where did that number come from? It's a very precise number. I mean, it doesn't have sense, but it's a pretty precise number. Where did that number come from? It certainly isn't divided by 12 in any logistically reasonable way. Are you going to answer, John? No. Okay, you think?
No, but I have something kind of to spin off that, but they saw, correct me if I'm wrong, they saw 45 or 50 people,
Who's
right?
that?
The accountability court.
Yeah, but they didn't end up incarcerated. Only
So
about
do they
12
only
ended up-
see these guys only see incarcerated people?
Right.
Mhm.
Right.
I just wanted to
And those,
clarify that.
those supposedly are all sentenced. They've been sentenced through the accountability court, but it's it's like 12.
Yeah. So,
It's a small number.
Well, he gets a little more by now, but not
By
not
now,
much,
this was
15.
presented in December.
Right.
This was presented to the Appropriations Committee
Hmm.
about the 20th, 18th, 19th, and 20th of December.
Gotcha.
somebody have a great answer for me?
Great is a.
Is that a standard too high?
Poor
That's an
Haley.
invitation.
I know.
I don't want
blame-
to speak for Dr. Uger, but I think he did testify to this last week, which is that if the capacity exists to serve more people than just those that are coming through the accountability court, they would absolutely like to serve those individuals. So I would be hesitant to say that 1 million is, as simple as dividing by 12 or however many individuals have come through the accountability court. But that's how much it is to stand up that program that will maybe hopefully serve more individuals. in the
Back to
future.
the chair's point, like the statutes has certain things that you can and can't do. I like to go 130 miles an hour on the interstate, but the law says I can't. So like you may want to serve, he may want to serve more, but the statute doesn't allow for.
That's what we're gonna check.
Yeah.
We just want, because there is a whole
Okay.
program that the fifth floor and DOC has developed.
Yeah.
To increase SUD services within our correctional facility. The commissioner could not share any of that prior to the budget being
Right.
presented. The budget has now been presented. I want to get that information so we can sit down with Katie McClin
Mhm.
and go through our MOUD statute and see what tracks, what needs to be updated. Because we may not need to do anything, we may have to do something because you're offering a different SUD services.
Mhm.
And it's across the board from what I've heard.
And maybe one way for me to understand is the cost per ADP is made up of counseling, medication,
No, it's a
surgeries.
separate, that's separate.
I know it's separate, but to get to the number that has had to increase because the ADP has increased, I want to know what's making up the cost per person.
Are you talking about the 3.5 million?
I'm talking about the average cost per person being served. What makes that up? Seeing two nurses, one doctor, surgery, MODUD, psychiatric care. I want to see what makes that per patient number up. Because when the numbers of patients goes up, obviously the cost goes up. But and the reason that's important is because now we're talking about taking whatever that lineup of services was and adding to it. Now we can understand why 1.08 million for How many of them?
So the
Yeah.
ADP driven costs or what we pay WellPath is all inclusive.
I know.
It's everything that they provide. That's not what you were asking.
Yes, I want to know what's included in it.
So you named many of them. It's pharmacy, it's offsite specialty appointments, it's in facility care. It's the staffing to provide that care, the administrative overhead, which is one of the smaller parts. Staffing at both the regional office and the site level. Trying to think.
No,
Okay.
just don't misunderstand me.
Okay.
I can imagine what the list looks
Yes.
like. I want to know how much you assumed for each person, because it's obviously an
Okay.
average,
Mhm.
so that we see that every
Yeah.
person that's being counted is on average going to see $250 worth of opiate.
I see. And you're interested in that at the level of the individual. Okay, so we would have to follow up. I
Right.
have the total per member per month that includes it all, but not,
Right.
this is pharmacy, this is staff.
Right.
And I will just give a heads up that one of those categories is correctional health services, which is going to include multiple other things. So that would include staffing. It's not it's probably broken down into 5 buckets.
I understand.
Yeah.
But the reason it's going to highlight things is because now we've got an additional $1 million on top of the 3.4. So it's either additional categories or more of what's already included. And that's what help us understand.
The 1 million, and we could actually, if we wanted, we could go to the end slide, but we also, do we want to stay on this, move into ADP? The 1.08 is staffing, and it is included in the staffing total that the per member per month is based off of. Because all of the costs are put in, that then come back out with the per member.
Right.
Sorry. So with the 1 million, whatever it is, 1.08, I'm understanding that it's covering whoever has been identified from the accountability court, which is nowhere near the capability of this group that has been stood up. And so we're not enjoying efficiencies of scale or whatever. I assume it would be somebody like Dr. Uliger who could best speak to what that team could do in
Yes,
terms of, population that they're serving with those enhanced services.
I think Dr. Uliger and Shannon, who's the Director of Recovery and Reentry Services for WellPath, could speak to it. I also think the original, back to where the number came from, had projections for people served in it that those numbers were based off of. The number of people coming through the accountability court hasn't reached that, but whatever those initial assumptions were, if we can relocate them, would speak to what the staffing was based off of. We're trying to serve X people.
And then 1.08 will cover that X amount of people until June 30th, and it could get somewhat larger, but then beyond that, you would need to add people or have a second team or whatever.
Correct, if we were to offer that enhanced level of services at other facilities.
Right.
And fully used the resources at the two.
Right.
In theory, maybe we wouldn't need as much because not as many people need that level of care. We don't know if we were to do that more robust assessment, how often people would have a finding from the assessment of needing that level of care. But maybe that is enough to cover other facilities. I just don't know yet because we haven't fully, pushed the limits of what we can offer and to whom.
But then also it's not possible to line up that amount of money with the purported end of the accountability court because we're talking about this service going through the end of the fiscal year, not through the end of this month. Yeah.
Going through what?
The end of the fiscal year through June 30th. regardless
So
of-
that leads to my question, what's in the governor's proposed FY27 budget for DOC for this particular program?
For the SUV, would be the 1.2. But it's not prorated, yes. 1.2 million because it would be for 12 months, not prorated. This 1080 is a prorated amount. Because it's not, it didn't get stood up for 12 months. It was just in the last
10.
6 months, 8 months, not even that.
It can't be 10.
Either 10-1 or 11-1 that it was based off of
But
starting.
the FY27 governors recommend for this enhanced SUD is 1.2.
1.2.
That's there it is.
And is that just for the Chittenden facility in Southwest?
That is for the same two that are currently in the mix, which is Northwest and Chittenden.
That 1.2 would notionally cover whatever number of people that team can serve for a full coming fiscal year.
Yeah, the 1.2 is the staffing for a year.
Yeah, everybody that could serve.
Yes.
Is capital bill doing that 1.08? Or is the big bill? is- Yeah.
It's a big bill. Don't get it confused with our
Yeah.
world.
I was just,
This is the
Yeah, I-
general fund, BAA, that House Appropriations Committee started working on about the 18th, 19th, 20th of December.
okay.
Before Christmas, and they hope to get the bill out next week.
So you had mentioned in your answer to Brian, you mentioned that somewhere there's an estimate that was used to make this number. Can you guys get that number and your rationale, like how you came up with the number? Pretty please. Also, sorry that we're being so hard on you, but we.
Are we providing a recommendation to approve? We providing a recommendation?
I mean, between the two, you've got almost $8 million.
Okay.
That's a big budget adjustment.
Yeah, it is. So if this were not filled to the team's capacity from whoever comes out of the accountability court, and it seems like given time, and that's not going to happen, then expand through the rest of the population as you described up into whatever that limit is, as soon as we can identify them. Folks who need
Yes.
these services, yeah. Like basically get the team up to capacity when you can, once the court is over.
Yes.
Okay.
And we would do it at the speed that we could fill the seats, so to
Yes.
speak. So WellPath isn't going to hire people that there's no one in front of them to
Yes.
provide the service to. Which, based on where we're at right now, I don't know if I'm going to get in trouble for saying this, but would mean we wouldn't fully spend the 1.08. Because that is based on a period of time and a full staffing that we haven't reached. So
I thought that was the minimum tapping, which is already in place. I misunderstood.
that's the minimum staffing for the original program design for 2 sites, but WellPath has not hired all those staff.
Right.
They're hiring very slowly, in fact, because the volume from the court
Right, right.
is much lower than projected.
Yeah.
Or- I should say, those initial designs, we were working with the information that we had, and so the pace and the volume of people coming in through that particular program is slower and smaller than
Right.
the numbers were based off of.
Yep.
You know what really frustrates me is when there's new initiatives done on the front end of a process in our criminal justice system. This is no complaint to you folks. But when there's new initiatives that are done on the front end of a process in the criminal justice system, there is going to be issues in DOC. There's going to be pressures put on our facilities, and nobody talks about it, and nobody explains it to the public. And this is a good example. Oh, let's work them through the court system really fast, because the judges, state's attorneys, they want to get these cases off their books, but then that's going to put pressure on DOC, and nobody's talking about it. And that really bothers me. And then we're caught with something like this. It's no fault of anybody, but it's being touted out there that, oh, people volunteered. We had a specific person targeted to work in the state's attorney's office, and a judge came out of retirement, but bammo, DOC's budget's going to go up because of it. Nobody talks about that. Just a comment.
My understanding,
Or at least it'd been nice for us to have a briefing and understanding, so if people ask us questions, which they do, we can actually have an intelligent answer instead of no.
Kevin?
my understanding is the ADP is actually for a range of individuals. Can you tell us what the range was
Yes,
and what you're working with now?
I made what I think is a very pretty chart to show you exactly that.
Sorry.
Can I quickly go through the other slides just to get to that? Okay, so moving on to the bigger portion of the increase, which is ADP based, which is the 3.5 if we're rounding. So the original contract with WellPath was based on an average daily population of up to 1,300 people. To your point, Representative, it is a 100-person range, and the calculations are based off of the middle, and we'll have a chart of that. Due to the increased population, DOC amended the contract in October to reflect an ADP of up to 1,550. So a range of 1,450 to 1,550, calculations based on 1,500. in doing that, we added between 9 and 10 full-time positions to the contract to provide that level of services to more people. So this chart shows, starting with the beginning of the WellPath contract in July of 23, 24, I could have said that wrong, FY 24, because we're in 26 now, excuse me. The number of people, and I just want to note, this is the bottom vertical axis is 1,100 people. So when you look at this with the axis of 0 to 1,500, it is much less dramatic, but I want it to be you to be able to see what's happening. So this is the average daily population, which is per month. The red is what the ADP calculation is in the contract. So it was 1,250 until we changed it. So what you can see is that really starting a long time ago, the average daily population was higher than what the contract was calculated based off of. And I think we've shared our contract has a clause that if that's the case, they have the right to negotiate. So now what we're doing is catching up to our ADP having been higher than the range that they're getting paid for many months now. So we went from 1,250 to 1,500 and that range. And so now what the contract states is that the ADP is in between 1,450 and 1,550. And their right now to negotiate is if it goes above 1,550. So some of what we were doing was anticipating continued increases in ADP and not wanting to have to immediately go back and up it because we'd already exceeded what we put in the contract. So that's the catching up and why there's such a significant jump of an increase in ADP, because we didn't do it for a period of time that theoretically WellPath could have asked us to do it earlier.
But if you're looking from a year and a half ago, our population has been increasing. And the bulk of that increase are detainees, correct?
Yes.
Yes.
So keep this in mind. The public wants us to lock up more people and take them off the streets. And your detainee population is going to increase, which increases the cost of healthcare and increases the cost of staffing and increases the cost in the DOC budget. So I just want folks to keep that in mind. And that's what we're starting to see as a trend. It's not so much sentence, folks, necessarily. Our detainee population used to be about 300. We're now over 500. We have about, I want to say almost 1,600 beds, not quite so. We have about 1,500 beds at most in our system. But of those 1,500 beds, about 900 of those beds are only general population.
Say it again.
About 900 are general population. The others are specific. Could be booking, could be infirmary beds, could be close custody beds, could be geriatric beds, could be mental health beds. So you're not going to put a person who needs to be in a general population in those specific beds. That's the pressure we're feeling in our correctional facilities. That's the pressure that our staff are feeling.
Yep.
So the more people you want to incarcerate, the more it's going to cost us. So just keep that balance. Unless we don't provide any services to it and we just warehouse, then that's a whole different story.
And editorial comment is, the reason we do that is because we believe that that cost is less than if the people who are hurting other people are out hurting people. Right?
More
We do
about
this, we spend more money in corrections because we believe that's a lower total cost to the civilization than the cost to those who are being offended.
Vermont Crime Research will tell you the opposite.
Yeah, I do not.
But that's why we do it.
No,
I
Vermont Crime Research, which we can have them in, will show it's different.
Yeah, but
They
that's
will
not
show
You want
it's,
rehabilitation, so do I. But the money is one way or the other.
I don't think we're making decisions about incarcerating people because it's cheap. Or because there's a better return on investment. I don't think that's happening.
we can get the Vermont Crime Research in and talk about that because they have done a comparison in terms of the cost of public safety in the community and the cost of corrections. They have done that comparison and we can get them in for that. About crime research, we can get them in, bring that out. So it'll be surprising, I think, for many people
But I
to see
think
the results.
Kevin's point is probably, I could be wrong.
Yeah.
That the general population who may not be privy to this data would generally speaking think, doesn't mean it right, that people on the outside just think you have the price that it costs society for somebody to be out breaking law versus locking them up. And they make those, we hear it all the time. I mean, we always hear, like, why is somebody back on the street, for example, about bail? Because they don't understand bail law, right? I mean, you know, so that it's not whether it's true or not, it's people's interpretation.
I don't think we're making that, this is.
Not here,
our
it's room.
topic. No, I don't think society is making that decision. I think society is very much returning to a lock 'em up mentality in a general sort of sense. I don't want to see the problems that I'm seeing, so they should be in jail. That's what I think is happening.
And that's why our detainee population is going up, which then that's why our average daily population calculation is going up. So let's get back to this because we've only got a few more minutes to go
We
here.
gotta get out on the floor. 10 minutes.
So we can go to the next slide. I just wanted to provide some high-level summary of what's happening with the changes in the contract and the calculations that were made that resulted in that final 3.5 number. So it was adjusted based on spending in years 1 and 2. So we had years 1 and 2 based on a budget of what we would spend in each category, staffing, pharmacy, et cetera. And then when they revised the budget for this ADP, they adjusted it based on what we actually spent more on. So for example, pharmacy and offsite services were increased disproportionately because we had under budgeted for them and other things were increased the opposite, right? They didn't go up proportionally. Overall, the ADP increased 20% and the annual contract amount increased 11.5%. So I think to your point last week, that's an economy of scale question. And also, you know, through analysis of what actually are the per person costs versus the ones that are system wide. And I think I had in a previous slide that just in terms of the staffing cost, which is one of many inputs, that's about 10 additional positions added to the contract to serve more people.
Perfect.
Yeah.
Okay.
So
That's just.
for this particular piece, what would be our recommend? You still got another sheet. Go ahead.
This is back to SUD, which I think we covered in
We beat it.
good detail.
We beat it to death. It required 7 new positions across
Yes, so
six.
in either the next slide or the one after it is the detail of the staffing changes. So on the left, these are the ADP changes alone. And on the right is the enhanced SUD services alone.
There you go.
And these positions are not all filled, again, because we don't have the volume of people coming through the court yet or at this time to need all those staff. And WellPath is not hiring them to have them sit in the facility and not provide the service.
Okay.
But the contract includes them. So when we, one way or the other, are ready to provide that enhanced care to whomever through the court or otherwise, they have the ability to fill those positions through the contract.
And I think it's semantics, but this end of your chart, you had the same amount of personnel to serve many more people. So they obviously couldn't spend as much time with each individual.
I'm
So
sorry,
I'm not sure, but
not completely following, you, but I'd like to.
this chart here,
Yes.
your personnel jumped up. For this period here,
Mm-hmm.
there was opportunity to serve the people, but you didn't have the people to do it. When you, instead of adding services, you were just able to provide the services that you wanted to within this red range. And you can't because you didn't have the people to do it.
Yes, I mean, services were provided to the people in custody with the existing staff.
Lower level.
It's hard to say how much more we would have been able to provide had we adjusted it earlier. But yes.
One last question. So on your nice little paper here, so it shows shows the 1.8 questions we've been asking. But what if those aren't hired? Do we still have to pay WellPath
Carry
Health money, or do we?
Carry forward.
So the way the contract is structured, if WellPath doesn't spend the money for most of the categories that make up the budget, the state gets the money back.
So it's carried forward in their
Does
budget.
that ever happen?
Yes.
Oh, cool. Thanks.
And that's true up until if they get right up at the top of the budget. And then there's negotiation that happens depending on how much over budget they go. But that hasn't happened.
I just wanted you to end on a positive. So
Yes, it's in there, but if they don't hire people, we don't spend the money. Sorry, Chair, I need to cut you off.
So what is the committee's wishes in terms of our recommend to approach? Want more discussion about this?
can we think about it for an hour?
Sure. Sure. Because we also have to hear back from Trevor. 'Cause he's doing
I
some
think we have to
more work.
wait till Trevor,
I agree.
right?
That's for the first part, the 3.1. This part.
This is what.
I can say that philosophically, I'm absolutely in favor of enhanced SUD services. I think we're doing the bare minimum right. Yeah, that's with a caveat that I wish we weren't doing it through privatized Medicaid, medical services, but we are. So, but that's just a philosophical statement.
My thing is, this paper would have been, this page, I would have honestly started with this page because we beat you up for half an hour about what this page answers. But mine is more a philosophical thing of whether, and that's not even philosophical, it's just legal, whether or not it's legal to provide to detainees, right?
We gotta update the law.
Right, I mean, which is on us, don't get me wrong, but like, I want to make sure that we're complying. And there is no, as the chair mentioned earlier, opportunities for lawsuits, not frivolous, but for obvious reasons that we can take care of in advance. So that's my biggest concern about the issue.
Sure, up and down.
So I'm not remembering what was officially in the so-called 14-point plan or whatever it was. Was this
What?
one of the 14 bullets or whatever?
Yes.
Okay.
What's that again?
I was just wondering if this enhanced FPD treatment for those coming out of the court was part of the 14-point plan. It sounds like it was. So that was the first question. And the second is sort of, we heard a speech, but I want to know who's going to own the ongoing expense, who's going to admit to what this is.
Pre-trial supervision.
Yeah.
DOC.
Mhm.
Because it's DOC staffing that's supervising the folks in the community.
Sorry, I meant to own in the sense of take responsibility for, not have to deal with. But who politically is going to own, who realistically is going to say, right? Because the accountability court is coming to an end. Notionally, according to the speech the other day, it didn't cost us much of anything at all. So,
I don't know. I
so if
mean,
we're going to talk about what we're going to say to appropriations, I mean, I sure would like somebody to say, yes, we're absolutely in favor of this, and this is what we're going to pay for it.
yeah, if it's ongoing cost.
Yeah.
But what I'm hearing from the administration is this enhanced SUD is something they really believe in. It's coming from the 5th floor. They really believe in it and they'd like to do it across the whole system.
Yeah, let's hear it full throated, totally.
And if we support that, there's going to be a cost to that.
Yep.
And we'll have to update our law on MOUD,
Right.
which is H32.
Yep.
That's where we're at.
Mhm.
Well, let's go to the floor. And then we'll be back here after the floor,
To wrap it up.
and let's hope. At least on this piece, and we'll hear the other piece from Trevor, the 3.1, he's still got some moving pieces for that. So we've left you off.
This wonderful chart talks about personnel, but I don't see any material costs, equipment costs, office costs. Is that on here someplace?
It is not in this
Okay.
deck, no.
So I'd be interested in
Yeah.
knowing the other costs that makes up the total.
Absolutely.
Just to see.
We have all that information.
It might be fun.
Thank you.
Am I way up? Oh, I'm sure it's fungible.
Thank you.
Thank you so
I hope
much.
it wasn't too bad for the newbies.
We're honestly.
Saved it up.
All right, so you have the floor, no?
What's that?
Aren't you up after the floor?
It's not me, it's the governor's bill.
I stand corrected.
All right,
We're still
I'm heading in.
That she needs you.
Well, I'll say it on the record.